for number one, shifting away from the M2 regulatory Treg tumor environment to one that is more willing to be able to attack the cancer. So we need to shift from M2 to M1 macrophages. We need to get rid of the Tregs and get more cytotoxic T cells. And so that's all adaptive immunity.
There's no one answer to cancer, right? We're all in our areas working to solve this problem that's called cancer. Not only the combination of natural with conventional, because I agree with Dr. Jones about, if you walk outside and break a hip, I'm not going to tell you go take more vitamin D. I mean, goodness gracious, we got massive tumor burden. We need to remove it. But, is there a place for systemic and intratumoral, and then pulling in natural therapies for that intratumoral and systemic approach?
So what I tell folks is that our immune system, and I'm really simplifying here, has what I call the 3 R's. So first of all, its job is to recognize. Then its job is to respond, and by respond, to respond appropriately. And then the third is to remember. Like, that is basically what it is. So I will tell you, and probably my colleagues here will tell you, that I've yet to meet a patient with cancer who has those 3 things working well.
Welcome to Prescribed by Dr. Nathan Goodyear, where integrative oncology meets holistic healing. This podcast is your home for the latest in innovation, exploration, and elevation in all areas of integrative oncology, medicine, health, wellness, and beyond. Join me and a host of other innovators as we go from practicing to prescribing. Your daily dose of wellness begins now.
Well, Dr. Goodyear here. Welcome to another Prescribed by Dr. Nathan Goodyear podcast. And I can't tell you how excited I've been to have this conversation with 2 innovators, but I gotta set the platform, gotta set the table first before we dive into these innovators, because we're going to basically open up a can of worms that a lot of people don't want to open up. Last week, about the last 10 days, there was some great social media traction out there by Dr. Mariano Barbicide. And by the way, he discovered, or is part of the team that discovered, the RAS mutations all the way back in early 1980s. That's an oncogene. Little FYI, it has immunogenic principles and properties, and we may get into that today or not. But what he did in this, which was really exciting in a mouse model, we think it was systemic, though it wasn't really we weren't made aware about what that was in the publication, is he took a pleiotropic effect. So what he did is not one drug for one treatment. That's the magic bullet theory. He said, well, let me give 3 different targeted drugs. And what I like about that is he used CRAS, used EGFR, and used STAT3 degradation. Now, you may go, what, Dr. Goodyear, those are drugs. They're targeted medications, but they all have immunogenic principles. But that pleiotropic effect by using 3 drugs is really what natural therapies do on their own. They're hitting touch points on many different areas. So I wanted to bring in fact, I just turned things around about what we were going to talk about because of this, in the news event, if you will. But I wanted to bring in 2 who I consider innovators in the arena of integrative oncology. Now, Nasha Winters, I've had on before. You know her. She's like my sister from another mother. I love her to death. She is an innovator on multiple levels, but where she, I think, shines is she crosses the aisle. She crosses the aisle from naturopathic to straight up conventional oncology. And let me tell you what, that is really, really hard to do, because everybody on the conventional aisle, they see the others in the naturopathic arena as having no cred. She's got it all. And everybody she talks to, she like wins them over. So I was sitting at a conference, AAMP in October, and I'm sitting next to Nasha. And she said, oh my gosh, I got somebody you need to talk to. Dr. Jeffrey Jones, do you know him? I go, no, I don't. So I reached out to him. And by the way, she's also a matchmaker. So going back to Fiddler on the Roof, though she's happily married, I'm happily married, Jeffrey Jones happily married. I feel like I was kind of in that, matchmaker, make me a match. So what she was doing was, she was connecting people, and that's what she does so well as well. And that's how innovation really happens. So I called and talked to Dr. Jeffrey Jones. I'll let him introduce himself and Nasha as well. But this guy is amazing. We've had a few conversations. He's a physician. He's a pilot, which my dad was a pilot, so there's some kinship there. But the dude worked for NASA.
Yeah.
You know, I'm like, not worthy, not worthy, not worthy. So that's who we have on the podcast today. And I want to talk about natural therapies from an intratumoral approach. That's the topic in this three-way conversation. We'll just see where it goes. Nasha, Jeffrey, it is so good to have you all on here.
What a joy.
Yeah.
Yeah.
Well, before we started to talk, Nasha, you were talking about how you and Jeffrey met and the conversations and how that ties into kind of the conversation today.
Cool. Well, I mean, first of all, what an honor to be here. I've been looking forward to this conversation, and it's been a long time since Jeff and I got to connect like this. So it's fun to be here with you, Jeff, or Dr. Jones. But what's really funny is I think context is everything, right? I'm a history buff. And so we have history in this room of how we all found each other. And I'm in private practice, a small naturopathic private practice in Podunk, Durango, Colorado. Pretty much this is well before my book ever came out. This is well before anybody knew my name out there in the world. And I was just doing my thing, because all the things we're talking about today are things that I was just doing in practice for years, you know? And I get this call from, well, I have this patient who wants to come to me who has been diagnosed with testicular cancer. And he is he's like refusing standard of care. I'm in an unlicensed state for naturopathic medicine, and I'm a naturopathic doctor who is telling this gentleman, honey child, this is exactly where standard of care shines, is in this cancer type. I am advising you to get the chemotherapy. And he was so frustrated and shocked by me making that, right? I think he thought I was going to tell him to go and I don't know, shake chicken feathers over his head or something, but I didn't. I'm like, you need standard of care here. So here's that example that Dr. Goodyear shared. It's like, I recognize our strengths and limitations in both of the environments, but I also told him I can absolutely support you through this process. So he hasn't really yet committed to what he's going to do, but a few days or maybe weeks later, I get a phone call from Mr. Dr. Jones, and I have no idea who this is. Again, I'm trying to play under the radar in my small town. And this person invites me to coffee, and I'm thinking, here goes my license, here goes my life's work. I'm going to get ripped, thrown under the bus, because he makes the claims, he's also been contacted by this patient. And, Dr. Jones is introduced to me as a urological oncologist who is a visiting oncologist from, MD Anderson and big name. And I thought, oh, I'm screwed. I mean, there's just no nice way around it. And what turned out to be a quick, 30, 40 minute coffee date turned in, I think, Dr. Jones, 4 hours, possibly. We just kept going. And what was so exciting is when I sat down with him, I was very much nervous and a bit on the defense. And he completely disarmed that with just his tell me, let's talk about things like high dose IV vitamin C. And let's talk about, you were just you were curious. And I will tell you, unfortunately, that is kind of a unicorn in the conventional oncology space, even today, because I'm trying to figure out how many years. This probably was 2010. Maybe.
Oh, I didn't realize y'all's relationship went back that far.
Oh, yes, way back. And he would come back and visit in Durango. And I'll have Dr. Jones fill in those details. But this conversation really came down to him sharing his history, which I'll let him share about his research using high dose IV vitamin C, and his history of being understanding of taking a multi-pronged approach to any patient and not getting seduced by the one target, one treatment, and understanding the importance, maybe he wasn't calling it that then, of terrain. And we just had a kindred spirit. And we've actually at that time started doing some other projects together. I think I'll pause there, but it was just that moment when I thought my career was actually ending, where Dr. Jones actually showed me a new and hopeful path forward.
See, Nasha's done plenty of podcasts, leading podcasts, so you can tell. Well, I'm going to pause there. So nice transition. Jeff, Dr. Jones, we've had a few conversations. Clearly, you have a relationship there with Nasha going back many years now. Kind of give the listeners and the viewers a little bit of your background, because I think it's quite a unique one. And I don't think anybody would look at NASA and say, yeah, there's no innovation going on there.
Thank you very much, Dr. Goodyear, for the opportunity. And thanks, Nasha, Dr. Nasha, for setting the stage for a little bit of history from my perspective. Um, as Dr. Nasha mentioned, we met while I was doing work in Durango, Colorado at a conventional medical center doing the urologic oncology thing. But prior to that, I had trained originally in general surgery, urology, urologic oncology, and then I took a little pause from that pathway. I had already been in the military as a reservist, and I transitioned to from the surgical area to flight medicine, to flight surgery, and I actually went back and got my boards in aerospace medicine, and at that point in time, was a Navy flight surgeon supporting various squadrons and different types of aviation platforms. Had gone to flight school, gotten my wings, and was very committed to the flight environment aspect of my career. And that's when I got a call from an old buddy that I used to work with at the DeBakey Associates at Baylor, and they were having some issues at NASA, and he wanted me to come help them with those issues. And lo and behold, because I was aerospace trained, I did a little bit of additional fellowship work and then became a full-time NASA flight surgeon for 13 years and worked with crews starting out in shuttle. Then space station came along, and we started supporting first with the Russians and the Mir station, and then built the International Space Station. And I was the lead flight doc for early ISS missions. And then we had a new NASA director, Mike Griffith, who wanted to go back to the moon and Mars. And so we started another program called Constellation, and I was leading the efforts on developing the medical support system for planetary exploration. And about that time, I got called up to go to the war in Iraq. So my squadron was deployed, and while I was gone, we had a new president come in, and they canceled the whole Constellation program and committed to commercial space. And that was the point in time I said, okay, I'm gonna go back to doing conventional medicine. And I was for a few years in Durango there while I was waiting for the job I have now to come open and the chair to be named at the medical school. But I became the chief of urology here at the Michael E. DeBakey VA, and we've been very active in developing new therapies for cancer. As Dr. Nasha mentioned, testicular cancer we do extremely well with a combination of surgery and chemotherapy because it's a very rapidly growing cancer and it's very susceptible to that. But the majority of the urologic cancers, renal, bladder, prostate, etc., do not do so well with those types of therapies, and we need something much better. And that's what we've been committed to, is developing better. And as you mentioned, multifactorial pathways. You can't do this with a single treatment element. There are none that work by themselves. The only chance we have is to synergize and use combinatorial therapy to be successful. So.
And you're both innovators in completely different ways, but towards a common goal. And I mean, Nasha, your personal journey and then your career shows how you've innovated on both sides of the aisle and for your own health, and you've just translated that to other people. And then Dr. Jones, Dr. Nasha, sorry, these are friends. So Dr. Jones, my editor's gonna be throwing stuff at me. Goodness gracious, Nathan, come on, you didn't have the coffee. But Dr. Jones here, going through that process of surgical training, which you always go into surgery with a plan, but then you have to innovate in many cases because everything just seems to have a knack for not going the way you plan. And then also, flight surgeon, and then on into NASA. So these people are bringing a strategy and a skill set of saying, okay, we need to work the problem here. We need to work a complex problem of cancer that I would put probably on the orders of going to Mars. So if we can go to the moon and we're planning to go to Mars, I think we can go after cancer in a way that actually provides better results than what we're doing. So, guys, based on the new results and your innovation, is the right approach for cancer the magic bullet, or is the right approach the multi-pronged approach, as you mentioned, Dr. Jones? What's your feelings on those questions?
If you're asking me, I strongly feel like we have to attack these slower growing cancers in multiple ways. We have to deal with the cancer that is rapidly proliferating, the high Ki67 cells, but we also have to deal with the cancer stem cells, which seem to be the reason why most cancers recur. And that has to do with the tumor microenvironment. One, the immunological response. How do we optimize the immunological response? And that may include even making adjustments in the microbiome, for example, which we often gets overlooked. But if you're starting to look at metabolic pathways, kind of like the Jane McClellan approach, then these cells are very clever. If you block one predominant pathway, they'll find another to utilize. And so if they were glucose addicted and you block the glucose access, they'll switch to glutamine. And if you block the glutamine pathway, they'll switch to fatty acid metabolism. And so we have to be smart, understand what these cells have the capability to do, and then attack each component individually, and sometimes multiple pathways at the same time. And I think that optimizing the patient's general health is an important part of this, and that's why we talked about the terrain, and the microenvironment, making it hostile to cancer but favorable for normal cellular function, especially immunological function. So I'm a big proponent of all of these things being engaged concurrently to improve the outcome.
Well, Nasha, when you look at well-differentiated tumors, they don't stand out. And so, chemotherapy, attacking high Ki67 rapidly dividing tumors like Dr. Jones is talking about, we have several patients. I told, Dr. Williams that what are we doing? A marketing campaign for liposarcomas? Because we have a ton of liposarcomas and I don't understand it. But, they are coming in with both differentiated and well-differentiated histological types, and those require different approaches. There's nobody that wants to be more natural than myself. And of course, you come from the naturopathic arena. But natural therapies, I'd love you to tackle this question. Sure. Naturopathic therapies can be a solo therapy to target cancer. I mean, there's been case reports published about that, and that's where we like to be. But I wonder, do they really shine in combination with other therapies, whether that's combination adjuncts with other natural therapies, or whether it's in combination adjuncts with conventional therapies? What's your take on that?
Well, first, I think that the concept here that we've been doing, I think at least since 1971, but likely even for a few decades before that, was to look for this magic bullet approach that this sort of assumed cancer is a single bad actor, right? So I just want to reiterate that because this is what the group is saying, and kind of simplify it and reiterate. Whereas what that microenvironment that Dr. Jones is speaking to, and what I speak to as the terrain, it sees cancer as a response to a dysfunctional environment. And so even when, and Dr. Jones, I appreciate you brought up like our colleague, Jane McClellan, like these are great, but people get out there and get very myopic on the pathways, but they forget, well, what made those pathways, or the hallmarks, but what made those hallmarks express? What was the reason behind it? And so I wanted to just highlight that, because maybe we can come back and dig into that a little bit deeper, that the pathway won't, addressing the pathway won't change the reason why it was activated or suppressed. Addressing the hallmark won't change the reason why it was expressed or suppressed. And so coming back down to, throughout my 30 plus year career, I've seen people just do standard of care. I've seen people just do alternative care. And truth be told, the people who seem to do the best, if we did our little bell-shaped curve, are those that do some combination of the two. And the thing I'd like to put on the table is that even the people who do combination of the two, it's even repurposing or using standard of care differently and using alternative care differently. Mm-hmm. So I don't think we have to hit it with a sledgehammer of full dose chemotherapy, for instance, when you're stacking it with other therapies that create a vulnerability to the cancer cell simultaneously, such as being in a fasted state or bringing on some extra pressure with hyperbaric or potentiating with things like high dose IV vitamin C to push an extra bit of oxidative stress into the cell, you actually need less of those sort of non-discerning napalm the field approaches that when you partner them in these sort of the right time, right dose, right duration combination of both best of alternative and best of standard, boy, how do you make a difference? And Dr. Goodyear, I think another thing that you brought up that brings in this conversation is we're seeing this on both sides of the aisle, if you will, that we get very protocol driven. You know, it's like, oh, here's the diagnosis, here's the single treatment, here's how we do it. But to both of you are speaking to the fact that you can take a single tumor and see multiple personalities within that tumor. So if you whack-a-mole one side, you will overly express another. And that, I believe, is why conversations like this must happen if we want to see a change in the field of oncology.
Dr. Jones, when you look at what's dominated, and Nasha as well, what's dominated the last, it seems like 30 years or so, is the kind of genomic paradigm coming out of the discovery of oncogenes. It seems like we've really pushed into that. But as you really start to look into these oncogenes, whether it's CRAS, whether it's CMYC, whether it's PTN, whether it's whatever, and nuclear factor kappa beta, hypoxia-inducible factor 1 alpha, they all have immunological impacts. So, for me, I think we're talking about innovating in combining or innovating in how we use natural therapies and how we're using conventional therapies. Where we at the Williams Cancer Institute are stepping into is we're going, maybe systemic has not been the right approach all along. Yes, it can be great for things like testicular cancer, leukemias, obviously, et cetera. But for many tumors that we see, and I'd love to get your take on it because we treat renal cell carcinomas as well. We don't see a lot of bladder. We have a phase 2 study recruiting in the US right now for prostate. But it's like when a tumor is sitting right there, right in your face, it's like, well, why can't we turn that into a personalized vaccine? What's your thoughts on that?
Okay, well, you touched on a lot of things, so let's take them individually. But before we get into the whole genomic or omics in general, I wanted to first comment on Dr. Nasha's remarks because I think they're important, and I haven't given up on all conventional therapy. I'm not saying that conventional therapy has no role in cancer care. I still, I'm a surgeon, of course, and I'm used to cutting things out first with open surgery, and then we evolved to using robots to take the cancer out. But we're evolving still, and now we're using focal therapy methodology, and we've employed HIFU for a number of years to treat prostate cancer, which is high intensity focused ultrasound. But now that has even evolved, and we've got new tools like the Edison histotripsy device, and so we have the ability now to basically liquefy tumors, and in the process of breaking up those cellular membranes, you're liberating tumor antigens, and those can be a very good source of a personalized immunological support for the patient, and that I think is going to really revolutionize our ability to combine conventional therapy with immunological therapy, for example. And I'll get to that in a moment. But first, to answer your question about genomics, and we have focused on genomics, and I think it's because it's something that we can fairly easily define. We can measure it. We can show how certain things are mutated. But if you look at a cancer like prostate cancer, the vast majority of the patients don't have intense mutational burdens, and they don't have these germline mutations. There's about 10-15% that do, but most of the time these genomic alterations are a consequence of the fact they have cancer and they have genomic instability, as opposed to the cause, the carcinogenic etiology. And so that's where we need to look at other things like the metabolome, and is there something wrong with the basic inherent metabolism of that individual? For example, nutritional deficiencies, or do they have an environmental exposure and now they have disruption of normal metabolism, or they have some epigenomic effect rather than genomic, it's epigenomics in the expression of their genome that is been dysregulated from a toxin, for example, that they're exposed to, or some other environmental factor. And so looking at purely genomics has, despite the vast amount of research and money expenditure for cancer research in the last 15, 20 years, has not answered the question. And I think we have to look at these other arenas if we're really going to be successful in understanding the carcinogenic process. And like Dr. Nasha said, to correct the terrain, to correct the inherent problem that existed in that individual that caused them to develop a cancer in the first place. So to answer your second question about where we're going from an immunologic standpoint, I definitely think that although we've been successful in some tumors with a kind of a generic immune stimulation approach, using things like checkpoint inhibitors, whether it be anti-PD-1, PD-L1, or CTLA-4 inhibitors. Yeah, that's a generic immune modulation. But we can be more specific, and we can allow the patient's immune system to be targeted for their own tumor antigens. And that's what we've been doing here for a number of years now at Baylor with Dr. Will Decker and some colleagues, Matt Halpert, where we are taking the patient's tumor.
Did you know that 77% of the people watching my videos, Dr. Nathan Goodyear, don't subscribe? By subscribing to this podcast, you get access to real-time, cutting-edge integrative oncology, next-generation cancer care, the future to today. So we need your help. If this information is valuable to you, I encourage you to subscribe, because what that's going to give you is access to me, access to my ideas, my thoughts that are going to empower you to elevate not only your cancer care, but also your health and wellness. Also, that'll help us to build this community of hope and healing together.
Developing a lysate and then harvesting the patient's own dendritic cells and priming those dendritic cells to those tumor antigens, both internally and externally, and then reinfusing or reinjecting those cells back into the patients. And that is now a laser beam focused those dendritic cells to present those tumor antigens to the cytotoxic T cells. And so the next phase, I think, now that we have that technology, is to optimize the immune system for, number one, shifting away from the M2 regulatory Treg tumor environment to one that is more willing to be able to attack the cancer. So we need to shift from M2 to M1 macrophages. We need to get rid of the Tregs and get more cytotoxic T cells. And so that's all adaptive immunity. And then maybe even use things like the interleukin 15 receptor agonist, Antifa as an example, that allow the natural killer cells, which are the innate immunity, to be stimulated. And the combination of innate immunity, adaptive immunity together, I think, puts a very potent combination, especially when those dendritic cells are able to pinpoint those precise tumor antigens.
Yeah, that's a great way to answer it. And I'm sorry, when I ask one question, I tend to ask two.
We're with you, my friend. We've got you.
Because, I only have a limited time here with you guys, and it's like, okay, I gotta pick their brains. Now, because there's no one answer to cancer, right? We're all in our areas working to solve this problem that's called cancer. Nasha, I appreciate the work that Dr. Halpert's done, and I think it's fantastic. And I love that you talked about intratumoral ablation with HIFU and the histotripsy, because we believe that that's critical to, in essence, opening up the tumor to the presence of the immune system. It's really interesting as I've been diving into the understanding of the tumor microenvironment, Nasha, Dr. Nasha, is it seems that most of the tumors just, the immune system just doesn't get involved. And whether that's described currently as immune desert, immune excluded, or even the immune system gets in there, but it's restrained, it's dysfunctional, there's T cell exhaustion or whatever. This is where I wonder about not only the combination of natural with conventional, because I agree with Dr. Jones about, if you walk outside and break a hip, I'm not going to tell you go take more vitamin D.
Right.
I mean, goodness gracious, we got massive tumor burden. We need to remove it. You got brain mets. You need to target it with stereotactic radiation. But in terms of trying to get the immune system in there, not just natural plus conventional, but is there a place for systemic and intratumoral, and then pulling in natural therapies for that intratumoral and systemic approach? Again, sorry, I think I just asked you about 5 questions.
I think I've got the gist of it, of where you're going with this. And so, first of all, one thing I think is just important is what I would always teach a patient. So I speak to the lay person. You guys are the brilliants hanging out in academia. I'm in the trenches with like the normal folks. Plus, I will tell you right now, from 1,300 clinicians in 46 countries, they appreciate when I share these metaphors as well. So, it's like we have to remember how to communicate this, to understand it deeply for ourselves, as well as to be able to explain it to a 5th grader. So what I tell folks is that our immune system, and I'm really simplifying here, has what I call the 3 R's. So first of all, its job is to recognize. Then its job is to respond, and by respond, to respond appropriately. And then the third is to remember. Like, that is basically what it is. So I will tell you, and probably my colleagues here will tell you, that I've yet to meet a patient with cancer who has those 3 things working well. And so we're able to test for the expression of those 3 things I just described. I mean, first of all, clinically, you can kind of see the pattern as it arises. So patients stop responding to therapies, et cetera. Second, we can see things in data. So like simply a neutrophil to lymphocyte ratio tells us a lot. And yet even a neutrophil to lymphocyte ratio shows us all-cause mortality, not just in the cancer discussion. So I think that's a really underutilized and very inexpensive test. And then things like today, we can do more, sexy testing like lymphocyte mapping and whatnot to know exactly what patterns are expressing. Is this more of a Th17 process? Is this more of a Th1 or Th2 dominance, or a combination? Is this more, like you said, the macrophage? We can kind of start guessing or elucidating on labs like just monocytes. If I start to see a sharp rise in monocytes, I'm worried about that macrophage shift that Dr. Jones just alluded to. Those are the things that start to tell me that the cancer is either A, hiding from whatever treatment you're bringing on board, natural or otherwise, or 2, starting to actually recruit, those cells to help, like those immune cells to help it, to support it along the way. So I bring that up because even my friends, so I love that you brought up Dr. Matt Halpert and their team. In fact, Dr. Jeff, we were just at Immunoscene 2 weeks ago in Cancun, and my husband, Dr. Jeff knows Steve as well, was just like a kid in a candy shop, being in their lab and seeing what they're doing here. Because what is happening in the future of this is this very personalized approach that you're using your own body's wisdom to create the response that's required for you in that moment. And what people like Dr. Matt and others are seeing is that there are certain patients who are going to hit this out of the park. Like, he has really good outcomes, but they're still, like, they get excited when you have a 20% response, whereas other standard of care gets excited if there's a 3%. Well, how do we make that better? And that's what he started to realize from someone very straight-laced from MD Anderson, a PhD immunology researcher, started to realize it makes a difference if the patient is very already oxidative. If their C-reactive protein is very elevated, they're going to have less response to even your own personal dendritic T cell vaccine. If you have had a round of antibiotics in the last 6 months, you are likely going to fall flat there. If you're under extreme duress, if you're in a sympathetic nervous system, that changes the expression of the immune system. So those are just some examples. And that's why I think it's time that we stop creating this separation of these conversations, because guess what? The integrative, the truly thoughtful, data-driven integrative practitioner makes standard of care work better. It's that simple. And the standard of care is less burdensome to the healthy body while potentiating it to the cells that have lost their way. when they, reach across the aisle as well. And so even with what we've done, and I really appreciate Dr. Jones, you brought up first the ICIs, like the Keytrudas and whatnot. Those were just sort of non-discerning things. And my gosh, the studies show 80% of the time pretty severe adverse events. And I see that all the time. But the crazy part is, out of his own backyard in MD Anderson, they had a MD Anderson prognostic score, which they developed in 2018, which I've never seen them once apply to a patient, which is asking just a few simple questions. What's the person's age? What's their ECOG, their general function? What's their lactase dehydrogenase level? What's their liver burden? What's their lymphocyte levels, their neutrophil levels, their platelets? And so when you hear that, that might not mean anything to you, but these were the types of patterns we were seeing in our own practices. But even the crazy Germans in the early parts of the 1900s started doing what they called an anamnestic evaluation for every patient that they even considered doing mistletoe with, which was in essence asking those very 7 questions. So they were like having their own MD Anderson prognostic over 100 years ago, saying these patients are going to have a better response to even mistletoe compared to these patients. And so I say that because when we can come in and change those like 7 factors and support those, these patients have much better experiences. And I'll be brief to say one more piece that really highlights this. So my friend and colleague, Dr. Luis Diaz, he was the original investigator on the mistletoe trial at Hopkins. He wrote the foreword to our mistletoe book. He's now head of solid tumor oncology at Sloan Kettering, but he made world news when he showed that he took 18 patients with colorectal cancer into complete remission, and everyone praised him and the drug Keytruda. Mm-hmm. But when you peel back the layer, you realize there was a common denominator of those 18 patients that was less discussed in that paper. All of these patients were basically under the age of 50. Okay, so very young. All of them were treatment naive. That's a big one, which meant that probably their MD Anderson prognostic score was relatively intact. And all of them shared the same mutation, which is a DNA repair issue, which is a Lynch syndrome process. So instead of saying the drug did the magic, it was the environment in which the drug landed in where the magic happened. And I feel so sad that there was such an opportunity when his work made headlines all over the world that we could have run with that information. And luckily, people like you, Dr. Jones, and you, Dr. Goodyear, are doing that. But why is that not common knowledge at this point?
Oh, I got
it's like,
well, first of all, alter call on integrative oncology. And I don't know Dr. Jones well, but I know the one extended conversation we had on a Friday one day. It was like, oh my gosh, this guy is like a brother from a different mother, just like I said, your sister. Because when there's alignment in purpose and influence and direction, it's like, okay, the more people like that can line up, the more advancement we're going to get. And maybe it's protection of your lane, so I've got this diagram of basically you got natural, holistic, integrative, and conventional all in their lanes on a highway. But integrative can basically weave in and out of each lane as it's needed in conjunction with those who are staying in that lane. So, I think we got to get back to what it is to be a physician. It's a teacher that heals. And I think by focusing on the patient, whether it's from whether it's from a pharmaceutical, big pharma, medical, surgical, everybody's going to quote unquote make their margins. But if we focus on patients, we're going to heal more patients, and that helps everybody because right now we have a crisis of trust. Patients don't trust doctors. They don't trust hospitals. That's a Journal of American Medical Association online journal last year. So what we got to do is band together, work together, find out where our common ground is and work together. Dr. Jones, Nasha mentioned mistletoe, and she's spot on. What is your experience or your thought process on using mistletoe, for example, in bladder cancer? And then as I already done, multiple questions here. You mentioned gut microbiome.
Mm-hmm.
So there's nobody that loves to wade through the crap than me, because the gut microbiome research on humans has shown can take a non-responder and make them a responder in certain types of cancer. So I'd love to get your take on both of those. Though they're broad, I see them as synergistic, whether that be mistletoe intravesical for bladder cancer in conjunction with BCG, and augmenting that with fecal transplant. But then if a patient's on renal cell, they're getting immune checkpoint inhibiting therapies, you can give a fecal transplant, and that's going to reduce the off-target toxicity that Dr. Nasha Winters mentioned, but it's also going to augment the immune checkpoint inhibiting therapy. Love to hear your take on those kind of two general questions.
Yeah, so I do think improving the immunologic state of the cancer patient is a huge, important priority for us. And Dr. Nasha has been an innovator in the use of mistletoe for that particular application, and I'm a supporter of that. But I think mistletoe can work in other ways besides just intravesically. There's a lot of people that give it, for example, subcutaneously. And what are you trying to achieve with the mistletoe? And I think that there are several things, but again, we were talking about, is the immune system in this regulatory kind of quenched state, and do we need to change it to a different, more active state that's going to seek and destroy abnormal cells? I hate to think of cancer as an enemy, but because it's self that's gone awry, but it's basically cells that are growing outside the normal bounds and characteristics that we expect cells to be in, and so we have to control them, and either we're going to re-educate them to behave like they're supposed to, or we're going to have to eliminate them, one of the two. But the immune system does that. It often finds cells that are dysregulated, and that's its job, is to kind of take care of those that are misbehaving. And mistletoe is one of those agents that can do that. And I think it's, again, shifting from a Th17 rich type of environment more to a Th1. And then I wanted to throw out that there are some things in conventional therapy that may help us in this regard. For example, if you give a low dose metronomic type chemotherapy, you can shift the M2 population more towards an M1, and maybe drugs like mistletoe in combination with metronomic chemotherapy, we can create a more responsive immune environment, especially at the level of the tumor. So the tumor microenvironment, that's the one we really care about. And then we can use other agents. I mentioned the NK stimulation with IL-15 receptor agonists like Antifa, and that drug is being used in combination with BCG because bladder cancer has for a long time known to be one that's responsive to immunotherapy. So mistletoe, Antifa, BCG, all of them have potential synergies together to develop an immune response to bladder cancer, whether it be within the bladder where it starts, or even after it gets outside the bladder when it becomes a muscle invasive and subsequently metastatic tumor. Now, regards to your issue on microbiome, I think the microbiome is huge part of influencing immunity, and we have this whole gut-brain axis that is part of the wellness programs that we need to codify and optimize. But there are certain species that, if they're present, they result in poor outcomes, and there are other species, if present, result in better outcomes. And so we need to shift the microbiome diversity to include more species, and to include the species that seem to be associated with better oncologic and immunologic outcomes. And so I'll just throw one organism out there, and it's not the only one, but Akkermansia muciniphila is one that seems to be associated with better responses, immune responses to cancer. And so how do we enrich that population within the gut. It's hard to do with probiotics per se. It's not an organism that's easily transferred. So you mentioned fecal transplantation, but the other thing is that we have to look at the prebiotics. We have to look at the food for these bacteria. What promotes these bacteria to grow? And we know, for example, pomegranates. Akkermansia loves to eat pomegranate digest. So we should make sure that our patients are fed the right prebiotics to allow the right species and the right diversification. They need to eat fermented foods, for example. We neglect a lot of these things, but the organisms that humans need are often present in fermented foods, and they survive through the GI system to end up in the colon if they're in that fermented food much better than if we take a little pill. There's even companies now that are selling suppositories to put them in from the backside, and maybe that's a better approach because a lot of these organisms, even if live, do not survive the stomach acid and the proximal duodenum with the digestive enzymes that are there. So I agree with both of you that that the immune system needs to be optimized, and we have to look at it from several different viewpoints and optimize each element if we're going to get a really successful response in controlling that cancer.
Yeah, we always love win-win in cancer care, integrative oncology, or anywhere. So pomegranates, aphrodisiac, and it's a prebiotic. Akkermansia to improve your immune system. Dr. Jones, I never saw that one coming. That's awesome.
Well, Dr. Goodyear, I'm the urologist here, but I did not go there. I stuck on topic.
Hey, no, I appreciate that. Dr. Winters, the gut microbiome is such a critical part to the immune system. And when we go back, because I was primary pelvic floor surgeon, but I was in that, OBGYN is my training. And really what that process of pregnancy and then birth and then breastfeeding is, it's immune priming events. It's seeding. But what we have, it's being described initially in the literature, is really some extinction events that are occurring in children in their gut microbiome. And then we compound it because of what we're doing to our soil, what we're doing to our nutrition. We're not feeding good, healthy gut microbiome. And thus we're basically leading to immature immune system, unprimed immune systems. We're actually, we're seeding what we're sowing today, which is more disease, not just cancer. Of course, that's what we do, but more disease. And your approach in that kind of holistic systems as a naturopath, how do we change that? Because he's right. We've got to focus on all aspects. We can't just say, well, it's systemic versus intratumoral, it's immune checkpoint versus natural, mistletoe, et cetera. How do we bring it all together? How do you do that? You do it so well.
Well, I mean, first of all, you got my wheels turning to think about, even what Dr. Jones said was we just give a pill for that, whether it's from the conventional side of things or the alternative side of things. And that is not going to correct the system. That's not going to reestablish the resources necessary for health, creation. So, but we do have to back it up. We have to back it up again, a historical perspective of what we've done. So in essence, since World War II, we have monocropped our food systems, and that was based on literally infighting, political governmental infighting that led to subsidizing farmers to grow certain crops that we were no longer able to get from other parts of the world. And we basically paid them to stop growing the diverse crops we'd thrived on for millennia. So that's one piece that happened. And so we basically monocropped the globe into soy, corn, canola, and wheat. I mean, and oats, those are kind of like the main things. We've always had we've known that our health and vitality is about diversity in our microbiome. And so when we monocropped our crops, we monocropped our crops inside as well. So that added insult to injury. And then I know Dr. Goodyear, I believe you interviewed Dr. Huber from Purdue University, who's now into his 90s, who's I want to cry every time I think about him. He is such a beautiful human being who started whistling, blowing the whistle on his concerns of what he was seeing in a lab in Purdue University back in the 60s, saying, this thing we're bringing on seems like we're bringing on for the help of the farmer, which was these like ripening agents and things to fight off herbicide, creatures and whatnot, which was glyphosate, Roundup. And so it wasn't ubiquitous into our water systems, air, and soil until the last 20 years or so. That was a huge pivot point, and I believe it's one that's really estimated in research and in clinical aspect. But what Dr. Huber taught me, more than a decade ago, was that the impact of glyphosate is basically a giant antibiotic to the soil. So again, if we talk about the monocropping problem, that's one. So food to our body translation. So that relational aspect. And then this antibiotic, even if we aren't taking the antibiotics, our food is eating that antibiotic rich food. And we are then eating that. And it's in our soil, our air, and our water. We've created this huge antibiotic. Please remember that we are mostly bacteria. We have way more organisms on and in us that make us up than we do our own cells. We have evolved from mitochondria, which started out as bacteria. And so when you're thinking about this ubiquitous antibiotic, that probably should get your wheels turning if there's probably a problem there. So when you say, how do we fix this? We don't go and fix it through medicine or a pill or a potion or a surgical intervention or a chemotherapy or a high dose. We have to go back to restoring the environment, that is making us now sick. So the environment within. So there has to be literally a grasping of hands between our farmers and our pharmacists, right? Our doctors and our stewards of the land. And so it sounds like so esoteric and maybe woo-woo, but you cannot heal the body from the environment in which it got sick. And that I think everyone would understand that. It seems like an intuitive thing here. So it really is important to start to become more mindful about what you're eating, where your food is coming from, building creating your own garden. 80% of us were farmers up until a few generations ago, or lived in those environments. Now less than 20% of us do. All of us, they even had during the war times, these war gardens. Everyone had their own gardens. Most people don't even know how to boil an egg anymore. And so getting back to the relationship with our food, our soil, and restoring that is actually the foundation of where this continues to go. And so in that, Dr. Jeff really brought up about eating more diverse foods. How many, folks in Kansas are eating pomegranates right now? It's that's one thing, but also, how many people are just popping a probiotic thinking that's going to do it? Not many people are drawn to the sauerkrauts and the dill pickles and whatnot, but cultures globally for millennia have depended on ferments as part of their daily nutrition. And our westernized cultures have really gotten away from that. So I know that was a very long-winded answer, but I feel like it's a bigger conversation to be had than just it's deficient of this drug or pill, take that and you'll be fine. We are an expression of the environment on and around us, and we're in relationship with that environment.
Yeah, so when you mention terrain, people think terrain inside, but we have to understand we're a product of the terrain we've created outside of us. So I think that's very well said. So obviously we could go on and on and on and on, but, and we focused on problems and areas where we see synergism that could be, impacted in research and application to help more patients. Just one point from each one of you. How do we move this forward? How do we keep from staying in our own lane, but start building bridges so that we can basically come together for that common purpose, both from a conventional integrative arm, Dr. Jones, and then Nasha naturopathic integrative oncology? How do we move forward building bridges to see that future that we desperately want to see for patients, not just in the future, but today?
Well, I'd love to jump in because I feel like that happened in this room. Literally Dr. Jones called me up and said, let's go have coffee. And instead, most people would either just make an assumption or make a judgment, but he moved forward with curiosity and a desire for just collaboration and understanding. And I came into it initially like, oh God, where is this going to go? And then also leaned into the curiosity and collaboration. I think that has to be both sides of the equation need to be willing to do both that. The other piece I think is really interesting, and Dr. Goodyear, you brought it up, Dr. Jones, you brought it up, we do now have a common language. We have the common language of epigenetics and microbiome testing. We have a common language that we can all come to and talk about together. We can understand hallmarks and metabolic pathways. Finally, we can talk about that, but we can talk about things like KRAS mutation responds beautifully to things like high dose IVC and therapeutic ketone bodies. Like those are things that we also then have pharmaceuticals for. There is a common language now that exists that I don't believe, and correct me if I'm wrong, gentlemen, but I don't think it existed 20 years ago. I mean, not even that much 10 years ago, but for sure not 20 years ago. And I think that there is an opportunity to see where we have common overlap.
Yeah, and work together. Dr. Jones, what's your thoughts on that closing question?
Oh, you're on mute.
Did we lose him?
No, he's on mute.
Okay.
Get your doc. That's right.
I'm sorry.
No, we're still
Okay.
I was trying not to interrupt and echo. No, I agree wholeheartedly with Dr. Nasha that we need to be collaborative and synergistic with our colleagues in the conventional space. I live in the conventional world, so I deal with it all the time. Unfortunately, many of my colleagues are not particularly open to things that are not on the NCCN guidelines or the AUA guidelines or whatever guideline, American Cancer Society recommendation list. And so when you get outside of that, they get uncomfortable, afraid somebody's going to call them out for practicing non-evidence-based medicine. So I think for us, we need to focus on taking good care of our patients and doing the right thing to improve the outcomes in our patients. And then we have a responsibility then to take that and publish it and show that these are evidence-based approaches to treatment, and use that evidence that we accumulate to show the skeptics, oh, well, there is scientific evidence to support some of these unconventional or alternative complementary. I hate a lot of these terms that are used, but that's what we're talking about. Out of the box thinking is being labeled alternative or complementary or integrative, and maybe Dr. Hasala is right when he says we need to call it personalized precision medicine and not use these other terms that immediately throw a target on our back that we're doing something that's outside of the standard of care. And what we're doing is augmenting the standard of care to better results, because they have to admit that standard of care is not getting the outcomes that we all want, and including the patient. And so we have to focus on our patients' welfare and our patients' outcomes, and then let the results speak for themselves as we take the responsibility to publish it and then distribute that information so our colleagues in the conventional world can understand that if they're going to get the results that we're getting, they're going to have to start changing the way they think.
Yeah, it's not enough to know the science. We have to be contributors to the science. And I believe it's, as you said, it's the research, the publication, the debate and discourse of ideas. I think that's the key to unlock, to potentially build those bridges. I mean, that's what we saw when we presented our updated data at ASCO, where there were comments from people that I was shocked to hear, that if you just deal in the science, because the science is there on natural, holistic, integrative, and conventional. Let's just focus on that language. And that's going to be what I believe unlocks that door and basically takes the impossible of this relationship and makes it possible. And I think two people right here that have already been involved in it and can be the linchpin that helps build more research along with others that are out there. I think that's how we change it. And I appreciate both of you being on this podcast. We went around the horn and back again, or a couple of circulations around the earth there, if you will, use the math, and I'm probably using that incorrectly. But anyways, how can people find out more about your work, Dr. Nasha Winters, and Dr. Jeffrey Jones, your work?
I'm easy. Just go to drnasha.com and that will start to get you down all the rabbit holes of the places where I'm hanging out these days.
You just got that name.
It kind of, not a lot of Nashas on the planet, so it kind of stands out.
Well, just very prominent. Dr. Jones?
Well, yeah, our work is kind of highlighted to some degree at the Baylor College of Medicine homepage and our urology department website. But I would say where we need to start finding out about each other is in our PubMed search. So as we publish these papers and we're starting to, I know that I have a lot of, let's say, talks that I've given that have showed up on various and sundry locations, whether it be from a podcast or just from a lecture at a science forum. I think that's how we need to be known, because we're doing quality work and we're discussing our results in a scientific manner that competes equally with what is happening anywhere else in medicine, and earn the respect of those that are harping on the evidence basis for our approach. And so I think it's up to us to show that our approaches are not only equally as valid, but maybe even more valid than some of the approaches that are being taken in the conventional arena.
Well, thank you both for spending your Friday morning with me. This is the Dr. Goodyear Prescribed podcast. These are innovators, but more than innovators, they're bridge builders. They're going to build the bridge from today's fractured medical community, and they're going to bridge it together, and it's going to create a bright, bright future for patients. I'm Dr. Nathan Goodyear, and this is the Prescribed by Dr. Nathan Goodyear podcast. As always, check out the show notes below for all the supporting evidence. We need your help. Please subscribe to the podcast, share it with those out there that would benefit, and we'll see you on the next podcast.
Thanks for joining us on this episode of the Prescribed Podcast. All references supporting this episode can be found on the prescribed.com website. That's pre-scribe.com. To get your next dose of medical innovation, make sure you subscribe to Prescribe. We'll see you for your next refill.